Good afternoon, everyone, or good morning for those on the West Coast. Thank you to everyone who's taken the time to join us today, and a special thank you to our phenomenal speakers. My name is Figueroa, and I am a senior staff attorney at Farmworker Justice. For those who are not familiar with our organization, we are a national advocacy organization based in Washington, D.C. that seeks to improve farm workers' living and working conditions. We advocate on a broad range of issues affecting farm workers, including immigration, labor rights, occupational health and safety, and access to health. We also collaborate with local legal services organizations and migrant health centers that serve agricultural workers throughout the country. A few housekeeping matters before we begin. First, an important disclaimer that this webinar is supported by a cooperative agreement with the Health Resources and Services Administration of the U.S. government. However, the content of this webinar does not necessarily represent the official views of or an endorsement by HRSA or HHS. Second, we'd really like to get a sense of who's joining us on the webinar today so that we can guide the conversation accordingly. So we kindly ask that everyone please take a few seconds right now to type in your name, organization, and location from which you are joining us in the chat box. Similarly, when we get to the question and answer portion of the webinar, please make sure to enter your questions in the chat box so that we're able to get to all of them. Today's webinar is going to be focused on medical legal partnerships. In a few minutes, Bethany Hamilton from the National Center for Medical Legal Partnership will be guiding us through what MLPs are, different forms that they can take, and the multiple ways in which they can serve target populations. Farmworker Justice has also published a companion MLP guide to the broader guides and resources that NCMLP has put together, focused on serving the agricultural worker population and highlighting some of the specific challenges with this population. Later, Aaron Voit and Dr. Caroline Kennedy will then be sharing their amazing work on the ground in Monterey County, California, addressing farm workers' health needs through an MLP, both before and during the COVID-19 pandemic. Before we turn to our speakers, though, I'm just going to talk briefly about the demographics of farm workers and why the MLP tool can be so powerful in working with this community. A medical legal partnership is a healthcare delivery model that integrates legal care into the healthcare setting to address social determinants of health. The crux of MLPs is really the recognition that social determinants of health matter. In other words, the conditions in which people live, learn, and work affect a wide range of health and quality of life risks and outcomes. Farm workers' living and working conditions are a prime example of this cause and effect, and the COVID crisis has particularly laid bare the ways in which these factors affect individuals' health. Farm workers do absolutely essential work that is often ignored and undervalued. They work long hours and face multiple occupational health and safety threats, including exposure to pesticides, heat stress, lack of adequate field sanitation, injuries from machinery, unsafe transportation, and unsanitary housing, just to name a few. Yet in spite of this, they earn low wages and many live below the federal poverty line. In a particularly cruel irony, farm workers and their families often face food insecurity due to this economic reality. The majority of agricultural workers are immigrants, and although estimates vary, somewhere between 50 to 70% of them are thought to be undocumented. A rapidly growing group within the farm worker population are H-2A visa workers, which you'll see a picture of the visa here. H-2A workers are here on temporary non-immigrant visas, and their visas are tied to their employer, which creates a great power imbalance and vulnerability for workers. The lack of permanent immigration status and the fear of retaliation in the form of immigration enforcement is something that affects farm workers' lives daily. It makes it harder for them to speak up when there are unfair or unsafe labor practices at their job, and it can also make it more difficult to access the services that they need for themselves or their families. Another major challenge for the farm worker population is lack of access to medical care. Few agricultural employers provide health insurance for their workers. Additionally, there are many practical obstacles to obtaining medical care for workers, such as the remote location of work sites, long work hours, lack of transportation, the cost of care, and also language barriers. All of these factors affecting workers' health already existed previously under quote-unquote normal circumstances. But now COVID-19 has exacerbated these health risks and the economic uncertainty that workers face. All these factors can also contribute to chronic health conditions such as diabetes, asthma, and obesity, which in turn increase the possibility of more severe cases of COVID-19 for workers. As the essential workers that they are, farm workers are continuing to work, often in close proximity to each other and without the proper personal protective equipment. They may be sharing housing with others that does not allow for an effective quarantine and may have limited access to testing and treatment. These are just some of the issues in the context in which the MLP model can serve farm worker communities and try to address these underlying issues. So without further ado, I want to present our speakers. Bethany Hamilton, who will be the first speaker, is the co-director of the National Center for Medical Legal Partnership. Before that, she served as Deputy Director of State Affairs at the National Association of Community Health Centers, where she led projects to expand Medicaid, defend the Affordable Care Act, and strengthen health center enabling services. Aaron Voit is the Medical Legal Partnership Managing Attorney at CRLA. After graduating from Berkeley Law, he started a medical legal partnership with the Monterey County Health Department to serve farm workers in the Salinas Valley. A team of CRLA attorneys is on site at MCHD clinics every week, working with providers to address the legal issues that affect patients' health. A major focus of the partnership has been interventions to reduce pesticide exposure among pregnant farm worker women. Other highlights include helping get bed bugs and mold out of patients' homes, making sure disabled workers get the reasonable accommodations and medical leave they need, increasing school-based services for special needs students, and connecting victims of intimate partner violence to immigration services. Our third speaker, last but certainly not least, is Dr. Caroline Kennedy, the Medical Director of the Monterey County Health Department Clinic Services Bureau. She oversees medical care at 9 safety net healthcare clinics, serving farm workers, families, and low-income residents throughout Monterey County. Dr. Kennedy is a leader in clinical care for underserved communities and a fierce advocate for her patients. She has spoken out about the healthcare needs of rural communities impacted by COVID, the need to better support pregnant farm worker patients, and how the housing crisis is impacting her patients' health. She has generously lent her considerable skills and passion to improving access to legal services for patients with health-harming legal needs. So I will now pass it on to Bethany, who will be walking us through what an MLP can look like.
Thank you, Iris. Good morning or afternoon, everyone. I'm going to go ahead and share my screen. And as we live in this world of technology, just going to ask our colleague Alexis to enable me to screen share, or Iris, I think it's Alexis, to allow me to share my screen. Leave someone else's screen sharing.
You should be able to share your screen now.
Okay, thank you. Perfect. Thanks for bearing with us, everyone. All right. So again, good morning or afternoon, depending on where you are. And thank you for joining us today to talk about this very important topic of addressing the legal needs of the farm worker or agricultural worker community. They have been at the front lines always for those of us to continue to sustain through every public health emergency, particularly what we're facing right now during a pandemic. And we should ensure, just like we do for ourselves, that our essential workers receive the type of care that they need. And often that care goes well beyond medical services. And that's what we believe we can introduce you all to in various ways to address when it comes up as a legal need. So what I'm here to talk about today really is the medical legal partnership. Before I go into medical legal partnership as an overview, I just want to note quickly where I'm presenting from. So I'm with the National Center for Medical Legal Partnership. We are an NTAP partner, but our mission and vision and focus really is to help really integrate the legal services providers into the healthcare system and bring their expertise into the healthcare delivery system to ensure that they're advancing both individual and population health as you all as health centers carry out your medical as well as enabling services. So I'll tell you a little bit about what that looks like, because what I just noted there was that there's the health system and we're embedding legal services, but I do want to stay on this slide for just a second to note that it's not just about the clinicians or the lawyers or the paralegals. You have the case managers, the social workers throughout the system that are working together in these medical legal partnerships that take on various iterations around the country, just like FQHCs do, to help address many of the problems at the root of health inequities. All right. So I noted that first you're identifying some sort of need that goes beyond the medical needs that are showing up. And in fact, you're right, you're identifying it, and we know this. Around 80%, if not more, depending on what research you're reading, of a person's health is determined by social factors. Those social factors do vary. It can come up in the nature of housing insecurities, utility shutoffs, as we're expecting an avalanche of throughout the housing crisis this year. And it can also come up in terms of legal status or employment or education barriers. And certainly, as we're seeing now, for the agricultural worker community, income or health insurance needs. Some of the screening tools you all are already using, maybe Prepare, which created by some of our other NTAP colleagues and friends, or perhaps you're using tools created through participation in accountable health communities. But what happens when you begin to identify that need and you're saying, hey, there's a housing need here, but I've got clinicians and I've got social workers. I don't know who else there is who can, within my workforce or staffing or partnerships with the other CBOs in your community, address that problem. In other words, what workforce can begin to solve those needs that you've identified as problems for your individual patients? That's where the medical legal partnership comes in. And I'll explain in succinct terms what that is. So your medical legal partnership, in the most basic of terms, is that intervention where your legal and healthcare professionals are collaborating together to help patients resolve their social, economic, and environmental factors that are contributing to their health disparities. These are the sorts of issues that you may not immediately, and I know we have legal services folks on the line here, and as I come from my law background, we're trained in law school to think like lawyers, and one of the first things you do is you issue spot. That is not expected necessarily of your social work or health community to immediately identify a legal issue, but there are, of course, as I suggested in the screening tools, those factors that may come up that may have a remedy in civil law. And by applying the medical legal partnership approach to your interventions, that's where you'll have the partners who are trained in legal services to be able to help you navigate that civil legal law system remedy. Okay, so you might be thinking, exactly what are the ways that I can begin to connect how the civil legal services system or lawyers are able to actually address patients' social needs? This is just an example from what's called an iHelp chart that we created. I can't recall how many years ago, but you can easily find it, as well as adaptations of it on the National Center's website. It's also in several of our toolkits. Our latest Health Center MLP toolkit also features the iHelp chart. But you can see in each iHelp category, income, housing, education and employment, legal status, and personal family stability, that there are certain types of social needs that lawyers can come in and help with. So for example, in the food stamps or SNAP benefits or disability benefits area of needs, there are oftentimes someone may face a denial of benefits or reduction in benefits or even an overpayment. And that's oftentimes where civil legal services, attorneys, staff, and paralegals can step in and help a patient come over as a client and navigate how to overcome that barrier to receiving, retaining those benefits, or if it's in the case, as I noted, an overpayment, or being able to fight that overpayment that very well could result in, and just like medical bills, an insurmountable barrier to being able to access and improve one's health. So this, again, this is just a way to sort of map how that social need comes up across to how lawyers can help in each of the categories. All right, so there are some ways to look at not just how lawyers can help, but exactly what an MLP or a partnership looks like in terms of activities. So taking a step back, I've mentioned civil legal services, and I just want to note that in general, your civil legal services community is sometimes called your legal aid community. But these really are like your sector of poverty lawyers who are trained in and are particularly adept at really understanding the body of laws, policies, and the systems, inputs and outputs that may affect the ability for your patients to overcome those social barriers or legal barriers that are preventing them from optimizing their health. So basically, if you look at our health center toolkit that we recently put out, you'll see that there are the direct legal assistant services. That's a category of activities that we consider core MLP activities. And then you also have a category of MLP activities where you may have the system built to provide additional trainings, to build up the capacity and skill sets of your health center workforce. So for example, you're using that screening tool, you can bring the legal partners in to help identify what are the specific screening elements that continue to come up, those factors that come up that may be ripe for legal intervention. All right, and then you also have your clinical level changes where you would leverage that legal expertise, and then policy level changes. So taking it from the patient to the policy level, we have seen health centers through medical legal partnerships really weigh in on the coalition level to change everything from HUD policies to address your lead issues, to ensuring that, especially during the housing crisis, individuals have the ability to take advantage of, know about, and take advantage of things like your eviction or foreclosure moratoria at the various levels, CDC, state, and local. So what I brought up on the screen, really, I'm not going to talk about all of this, but I do want to just highlight that there are various components to a medical legal partnership, making for the variation in what you see in terms of what a partnership looks like throughout the country. You may have a lawyer in residence, you'll have certainly formalized agreements, but in that third in purple, if it's showing up on your screen as purple area, that's where you may have a medical legal partnership focus on a target population. You don't necessarily have a medical legal partnership. You don't necessarily, have to build a medical legal partnership to address all of your patients' needs, but you may want to look at targeting a population for a specific issue for both screening and addressing your legal needs. Okay, so the various partnerships around the country are in fact growing, and what we found through our work at the National Center and surveying of the field is that thus far we have identified for formalized MLPs medical legal partnerships in about 49 states plus DC. We know we don't have them all, so it's probably everywhere. But that 450 number represents the medical legal partnerships that are at health orgs around the country. And you'll see in the bluest area of the pie chart, 163 HRSA funded health centers with formalized medical legal partnerships. That in fact does represent where we see the fastest area of growth in terms of health system partners with medical legal partnership adoption around the country. And as we continue to look at the UDS, we do know that folks at health centers are providing enabling services that amount to legal services. So perhaps there is not yet a formalized medical legal partnership, but we know that at least for health centers, there is certainly growth in ensuring that they are identifying civil legal services needs and then finding some ways to connect with legal partners at the community level. And then our job as the National Center is to ensure that folks know how they can grow, develop, and certainly advance and evolve in that area. The impact is seen, and we're picking it up through various studies. The National Center, if you go on our resources section of our website, you'll definitely see a recent literature review that can, and several other studies and issue briefs that we've done to show that for people with chronic illnesses, medical legal partnership has been shown to reduce those hospital admissions. For individuals for whom you are particularly concerned, I think for the clinicians on today's webinar, with regard to medication adherence, depending on the condition, MLPs have been shown to allow for people to more commonly take their medications as prescribed. And certainly less money has been shown to be spent on healthcare services for people who would otherwise frequently go to those more expensive and preventable healthcare places, such as the emergency room at the hospital. So I would say, and I don't want to steal any of our talking points from my colleagues coming up next, Erin and Dr. Kennedy, but I just want to highlight very quickly that some other areas where for the agricultural worker community, there are benefits shown of medical legal partnership. Just one quick example, MLPs have been shown to assist injured or ill agricultural workers, help better navigate the benefits that they deserve and are certainly eligible for. And I will note that, over the last few years, we have seen a lot of barriers that have been, have added a level of fear and intimidation around understanding how to begin to jump several hurdles. So as folks continue to stay out there as our essential worker community to provide for all of us around the country, we're really hoping that folks can continue to collaborate so we can continue to have an impact in terms of supporting agricultural workers. Excuse me. How can we help you? We do have some resources, quite a bit, and I speak for the National Center and our Farmworker Justice friends here. First, I'll just highlight the National Center recently published our Health Center MLP Toolkit, so you can, I believe we've built in links at the end, so you can get to these easily on our website. I mentioned that I'm going to take liberty to highlight our friends at Farmworker Justice, a toolkit that they also put together. It's the MLP Guide for Agricultural Worker Serving Organizations. And then finally, throughout the COVID crisis, we knew this was coming, and it's the eviction and foreclosure crisis. And so in terms of everything being thrown at you and ensuring that you don't have to necessarily go straight to a 70-page or 14-page brief, I want to help save you some time and just point you to a one-page document plus some other resources that you can reach. If you go to our National Center resource page, you'll find this 3 ways to help patients with evictions and foreclosures during the COVID-19 pandemic. I'll also encourage you to feel free to reach out to me. I'm Bethany. I have several colleagues, such as Danielle and April, who are also here on the line, and our co-director, Joel Teitelbaum. We're ready, willing, and able to assist you. For now, however, I do want to turn it over to our esteemed colleagues in the field. We have got Erin and Dr. Kennedy to explain what this looks like on the ground and how they can provide an example that you might be able to replicate to support your patient populations. I'm going to stop sharing my screen and go on mute so that Erin and Dr. Kennedy can speak. Thank you all.
Thanks, Bethany, and it is an absolute pleasure to be here with all of you today. And I am also going to share my screen for our presentation, so please just give me a moment. Okay, wow, that actually worked a little bit this time. Hi, everyone. Again, it is a pleasure to be here with you today and an honor to hold space with so many amazing advocates and providers from organizations across the country working really hard in this challenging moment to be there for our communities. And it is a really challenging moment, and I'm sure many of us are feeling tired, and it's always really inspirational and brings a bit of hope to connect with others that are in this same fight and that are doing such important work right now. And so while Dr. Kennedy and I are here to humbly share a bit about the initiatives that we've tried to put together to respond to COVID and support farm workers in our community, we know we also have a lot to learn from those on this call as well, and hope that there'll be spaces during our presentation and in the question and answer afterwards to hear about some of the great work you all are doing and to have an exchange around ways that we might learn from one another, and in the spirit of our medical legal partnership, look for opportunities to work across fields and collaborate and see how we can do more together. So on that note, I just wanted to very briefly introduce myself and pass it over to Dr. Kennedy so that she can talk a little bit about her work with the Monterey County Health Department. My name is Voit. I'm an attorney for California Rural Legal Assistance. We provide free legal services to rural low-income Californians and serve farm workers all across California. I am based in Salinas, California, and run a medical legal partnership with the Monterey County Health Department. But I see we are joined here today by some of my CRLA colleagues that are doing incredible work all throughout the state. And what we're doing here in Monterey County is supported by them. And it wouldn't be possible without the amazing legacy that California Rural Legal Assistance has here in California. And I'm thinking in particular of one of the community workers at our Salinas office, Hector De La Rosa, who has worked for CRLA since day one in 1966 for over 50 years, has a street named after him here in the area, and sadly recently passed away. But it's his legacy and the lessons that he taught me and others that we carry forward in the work that we do. And so he's on my mind today, and I just kind of wanted to give him a shout out, and I'm really feeling his spirit and the meaning of why we do this work today. So thank you all for that opportunity. And I want to pass it to Dr. Kennedy so she can introduce herself and a little bit of the work that she does at the Monterey County Health Department.
It's wonderful to be here. I'm a family physician. I'm a bilingual family physician, and I practice medicine in one of our clinics. And I have had the pleasure of being part of this community for 22 years. And I think that has allowed me to have a dramatic impact on our who we hire at our organization, what our attitude is, how we have changed to bring quality to our patients. They deserve the highest quality care. And I have been very, I think working with Erin in CRLA has really added a whole nother level to what we do for our patients. And I would not have dreamed of some of the things we've been able to do if it wasn't for the attorney telling me we could do it together, going to the Sacramento and getting them to change the rules so we could call pesticides and pregnancy and disable women when they test positive for pregnancy. Some of these things I was thinking more local, and really partnering with Erin has made me think more global. And I know every provider in our organization knows Erin, communicates with him, and he has brought us all along to become better physicians for our patients.
Thank you, Dr. Kennedy. It's really been a team effort, and we're excited to kind of highlight some of those lessons that we've learned with respect to COVID today, and with the hope that it can potentially share some replicable initiatives that we think have been important to our local community, and also start a wider conversation about some of the work that everyone else is doing and how we can learn from one another. But before we get into that, we want to say a huge thank you to the amazing essential workers that are putting food on our tables right now. And this presentation is about how we can support farm workers during these really difficult moments. And it's really important for Dr. Kennedy and I to acknowledge that right now, as we're giving this presentation, there are farm workers out in the fields in Monterey County making huge sacrifices to put food on our plates and to provide for their families. And we really want to honor that work. And it is a huge honor to support them. And also to our frontline healthcare providers. And we have a provider here on the screen, Dr. Pedro Moreno, who is an amazing primary care physician at one of Dr. Kennedy's clinics. And I see the sacrifice he's making, the sacrifice Dr. Kennedy's making. It is an absolute privilege to work alongside our healthcare providers, and you all are our heroes in this moment. I won't spend a lot of time talking about some of the social determinants of health that are impacting COVID among farm workers, but just wanted to cover a few of them that we've come across here in Monterey County as kind of a foundation for some of the later topics that we'll cover as we look at 3 specific initiatives that we're undertaking through our medical legal partnership. 1, improving access to replacement income. 2, reaching out to H-2A workers. And 3, building coalitions with other stakeholders so that we can create systemic solutions. But before we talk about those 3 initiatives, I wanted to just run down a bit of background about why farm workers in Monterey County are 3 times more likely than any other workers to contract COVID. And in part, that's because of the healthcare inequities that we've had long before COVID. A large percentage of our farm workers are undocumented, and even more come from immigrant communities. And there's a long history of those communities struggling to access healthcare because of a lack of health insurance coverage, or because of their experiences trying to access care. And so as we're trying to help folks access care now in the time of COVID, we're coming up against a long history of those inequities and trying to create, get information out there and create services that can help address that. We also see in farm work that there can be easier transmission than in other industries and professions because they are essential workers and out in the fields and in the packing sheds, when many other workers haven't necessarily been out in their places of work at the highest risk moments. There can also be challenges with social distancing, and in the picture, you can see a lettuce harvesting machine that has specific placements for each workers, the 20 or so workers that are on that machine. And oftentimes those placements aren't 6 feet or more apart. And so it can be difficult to social distance in some of the structures that are built around farm work. We have a housing crisis here in California, and that's true in Monterey County, where a 1-bedroom apartment can cost over $1,500 on average, despite the fact that farm workers make an average of around $18,000 a year. And so many families are living together in crowded housing and in substandard condition, and that only exacerbates the issues that we're confronting now during COVID. And of course, ride sharing to and from work is a common practice, and also a time that can increase the risk of COVID transmission. We're also seeing decreased access to testing and contact tracing. That can be in part because of the lack of testing facilities, or the way testing facilities are impacted in our most vulnerable communities, but also because of fears around if farm workers do get tested, what will be the impact on their ability to work and earn income and provide for their family. And so we're seeing a lot of social determinants of health in the area of the disparity and inability to access testing and to be contact traced because of language access issues, cultural competency improvements that we need to make as a county, all sorts of different reasons why we're seeing increased challenges in that area. And then lastly, we see comorbidities and chronic medical conditions that can put people at higher risk, and that includes diabetes and obesity, and several others, and some that are particularly associated with high risk work like agriculture. Here in the Salinas Valley, I just wanted to give you all a bit of orientation to where exactly we're at. We're in what folks call the salad bowl of the world. We have an over $4 billion agriculture industry in our county alone. We're about 2 hours south of Monterey. We're about 2 hours south of San Francisco. Part of the county borders the coast, and then the Salinas Valley heads inland. At the height of our season, we have over 90,000 farm workers that are in our county alone. There's about 800,000 farm workers across California. And our county is not one thing. It's not just agricultural workers. And we see huge disparities between the Salinas Valley, where our agricultural communities are and where our fields are, and Carmel and Monterey, where folks think of Big Little Lies or Pebble Beach, or some of these other areas that have a much different demographics and composition. And so we see huge differences among those two populations, and a huge need to address those disparities by coming up with concrete initiatives that can address the social determinants of health to close those disparities. So at this point, I want to pass it over to Edith from Farmworker Justice and Dr. Kennedy to talk a little bit more about Dr. Kennedy's day-to-day work in the clinic and the services that they're providing with relation to COVID, and some of the experiences that Dr. Kennedy has had with her patients and in that work.
Great, thank you, Erin. So we just want to take a few minutes just to have a little bit of a conversation about what's happening on the ground and what we're seeing before Erin moves to some of the specific initiatives. So Dr. Kennedy, what is it like at your clinics right now?
So I live this since the day the pandemic began, but our clinics no longer have waiting rooms. We have some tents outside, and we have a Mediterranean climate, but recently a few of our tents flew away. So we're scrambling to try to figure out how to have our patients waiting outside instead of waiting in our building. 50% of the visits are telemedicine, either by video or by telephone. Some of that has been really good for patients because we did a number of visits in the field, or I did one recently with a person standing at work, and I can tell that they can take a break and speak with me. But that has been challenging for our patients as well. Some of them want to see their doctor more face to face, and our building is not set up for us to do it safely. We can't have them all in the waiting room. We can't have them bring all of their family. We allow them just to bring one person. So I think it has been stressful for all of us. We have this higher demand for services. So maybe 2 months ago, we were testing 10 people a day, and now we're testing 120 a day. And so we have the same staff, and now we're a little bit more exhausted. And so 1 week to the next, we have to pivot to do completely different things. And that impacts our patients' ability to get in to be seen for an ear infection and other things. We are doing now rapid testing, which is 15-minute testing for all of our patients that have any symptoms, which is very, very proud that we can bring that to our community. I think that the social determinants of health needs have just really become more in the forefront and more dramatic. We've had a lot of them always with, food and housing and everything else. But there's so many things that have added to that we pivoted our social workers to do more counseling before for, depression and anxiety. And now they're really focused on this huge volume of we call them COVID social worker referrals that we make when we ask patients that have any problem. And they've been amazing collaborating with CRLA and really pitching together. We have 3 of them we see 650 people a day, and we have 3 social workers. So they really come together and share and do amazing things for our patients. One of the things that looks different at our clinic, which maybe most people don't think about, is our physicians and our staff are very terrified. And so the cold weather is bringing more people in. We find positive asymptomatic patients. We test our OB patients before they go to the hospital, and we find people that were walking with us, in the rooms, all positive. And that has really caused a lot of trouble. So we're trying to be very understanding of our workers, but it is frightening for them. We don't have a vaccine, and they really fear their patients sometimes, which puts them at odds with the patient that wants to be seen with their baby with a fever. And they'll tell me, no es justo that my doctor won't see me, but the doctor's frightened to see a baby with 103 temperature. So that's how things have kind of changed for us dramatically.
Yes, definitely. And how have your farm worker patients been impacted by COVID in disparate ways? I
mean, the disease itself, for the summertime when we had all the agricultural workers, we have one of our clinics in 93906, which was just amazing high percentage of patients. The disease, sometimes people would call us and say, I need to be tested, but I'm going to my uncle's funeral today. And everybody in my family is positive. You could see it when a mom would drive up and say, my husband is hospitalized and she's clearly has a fever in the car, and she has her 2 kids in the back seat. And it's just, it changes. When I was doing the swabbing for a while and leaning into the car and talking to the patient, it just changes your perspective on what this really means. And we are the haves and the have-nots. And so the rate on the peninsula was really low, and the rate in East Salinas was really high. I think for them also, they've all had huge decreases in income. Some of them, they would be put off work initially for 2 weeks or so, and they'd need extra negative tests. And it was really, I'm sure they missed multiple days, not to mention the fact that they say that the kids are home. If they were at college or they were on their own, they all had to move home. Their type of service industry jobs went away. And so now they have more mouths to feed, more people to house in their houses. I mean, it is more stressful, less money. I think that there's, just like our own employees, the daycare's closed, the school's closed in our county, and they have to leave someone at home to take care of their extended family. So money is just so much tighter. And as maybe most of you know, in the winter time, our patients sometimes stay in the area, but they're living off all of their income from the summer. And so there's less income this summer, and there's more mouths to feed.
And you mentioned testing earlier and being able to provide some testing, but what are some of the challenges that you've seen with testing and then quarantining if there is a positive result?
Yeah, so I'm on the part of the EOC of our county. I'm the medical director of the EOC for, and so I meet with the police and the firemen, and they're all confused about where to get tested. And you can imagine if that's difficult for them, it's difficult for our patients. The locations of testing is not really built for our patients. They're, most of it is online. You can call in, but the ridiculous thing is you need to know 2 or 3 days in advance if you're going to feel sick. I don't understand how anyone would know that. And so I don't think that's a functioning system for our patients. Maybe 4 to 7, they'll take walk-ins, but it's also sometimes not located in the right place. Sometimes they'll have pop-up testing in one, South County, which has less testing, but it's on Tuesday. Well, how many people are sick on Tuesday? And so I find that that's just really not helpful. I think that sometimes people have H2 workers that I've seen, they are isolated in a hotel way away from a clinic. They don't have established relationship with the clinic. They don't know where they would go. Initially, we opened up our clinics to test anyone, even if you're a new patient and you've never been there before. And I think the first day that I was doing H2 worker screenings, they just passed the phone from one person to the next. And after, when they said, oh, the next person wants to be tested, and they just handed the phone to them, I just was dumbfounded that, well, if you weren't infected before, you're all sharing the same cell phone to tell me about that you want to be tested. And then they would drive up 5 or 6 people all packed into one little small car. And, it kind of breaks your heart, and you can understand what's happening. And they can't, this is just the density, and they don't have a way to get to so I don't think them driving to the clinic, 5 people in the car is optimal. I just want to say too that, replacement income is hard for them, and employers are not really that easy to deal with. And for a while, the county told us to please don't do a second test to make sure they're negative. And I told them, I'm sorry, I'm going to be testing anyone who needs it, because if it saves them 1 day of income, a negative test, that's what they need. So we have always done whatever our patient needs to get back to work, even if it doesn't make sense according to the CDC guidelines. I sometimes encourage people, would you like to have other people in your household tested? And they say, well, is it obligatorio? And I tell them, absolutely not. I know that with a positive test comes quarantine for 14 days. And if you're sometimes there's a confusion. You test positive, then your wife tests positive, then your child tests positive. The quarantine can seem to go on forever. And so I can see the fear in what's in it for me. If I get my house labeled as a quarantine house, then I can't go back to work. And then how am I going to get my papers? So I have many opinions about how we could improve testing, but I don't think it's set up for people who don't have computers and printers at home. And I would love to see it done differently.
Great. And so I think Erin is going to address a couple of the issues that you mentioned, especially particularly H2A workers and the issue of income replacement and how important that is.
Yeah, absolutely. And thank you, Dr. Kennedy, for sharing your experience, because I know we're in the middle of a really difficult moment, and there are so many things that we need to do in order to help the people that we serve, and it can feel really overwhelming. And one of the things I've really appreciated in working with the Monterey County Health Department is that in teaming up together, I think we see new opportunities to increase the impact that we can have, and to really problem solve in ways that we can't do alone. And I know in working with you and with your staff, it's opened our eyes and opened doors into ways that we can be impactful in our communities that we couldn't be otherwise. And that's really a feeling that is so precious in these moments, and an impact that we really need. And so I want to, in the many things that Dr. Kennedy flagged of how COVID is impacting her farm worker patients, we wanted to focus on 3 in particular. And the first one is access to replacement income. I see here my slides need to be full screen. Okay, there we go. So right at the beginning of this pandemic, we saw something that I'm sure you all have seen in your communities across California and across the country, which is that for low-income workers living paycheck to paycheck, which farm workers are often in that predicament, it can be really difficult to go get tested when there's a possibility that you're going to be ordered to stay out of your workplace for 10 or 14 days and to lose that income. And if you're COVID positive, it can be difficult to quarantine and to care for yourself and not feel that pressure to return to work immediately when you might not be feeling healthy enough to do so, especially for the physically demanding work of farm work, Or if you have a loved one that is impacted by COVID and you need to care for them at home, how can you take that time off work to do so when you need that money to pay your rent and to buy food and to put clothing on your family's back? And so we saw as a barrier to getting tested the social determinant of health of replacement income. And that was a huge issue that we needed to address if we were going to ask our community, our neighbors, our friends, the people that we serve to go get tested. We had to have an answer to that question. Or, well, what am I going to do if I need to miss work for a certain amount of time? And so we had a goal, which was to improve access to replacement income and job protected leave. And we designed a medical legal intervention that could help us get there. And we're still on that journey. We're nowhere near what we need to be, but we're a lot farther along thanks to the joint efforts of the Monterey County Health Department and our amazing team at CRLA, as well as our community partners that are a huge part of this initiative as well. So the first thing we did is we knew we all had to learn a lot more about what programs were available to farm workers to help them access replacement income. What were those programs? And so we're really grateful to the federal government for the Family First Coronavirus Response Act, which can provide up to 80 hours of paid sick leave for some farm workers that are impacted by COVID. But there are huge gaps in that law as well. And California took a step forward and created a supplemental program for our state to try to fill some of those gaps. And thanks to some of the other programs that we have at the state and federal level, at this moment, and unfortunately it's going to change a lot come the new year unless both the California legislature and our federal government does what they should do. But for at least for the moment, almost all farm workers can access up to 80 hours of paid sick leave here in the state of California if they've been impacted by COVID. And it's really important that we trained all our primary care physicians, our medical assistants, our social workers, our PSRs, everybody that when a patient said, I'm not going to get tested because I can't afford to miss work, that they knew that they could respond by saying almost all farm workers in California can get replacement income if they need to miss work due to COVID. So it takes a lot of work to get to that point, and that was part of the legal side of this work, was to do the research and to put together a guide, and you see a link to the guide below. That guide is California specific, but our great colleagues at Farmworker Justice just put out a policy brief that talks about replacement income programs in all across the country, and that's an amazing compliment. And for those joining outside of California, that might be a great resource if you're looking to get more information about what programs are available to farm workers in your area. So that was the first thing, is we needed to do the legal research and get these programs in a very easily understandable way. And this guide was our version of that. And then we needed to train our healthcare providers so that they could be those issue spotters that Bethany referenced and connect workers to the services they need to access replacement income. But we didn't stop there, because that wasn't enough to actually create the change that we needed. And we actually designed a new initiative to create a 1-800 number that any rural low-income worker in California could call. And here in Monterey County is the home of that work, and over half our calls across the state come right here from Monterey County. And they can talk to an attorney to understand what program might be the best fit for them and overcome any obstacles, like an employer crumpling up their request that they filled out and throwing it in the trash, or being fired because they requested paid sick leave, or all these other really terrible things that sadly we're seeing. And there's some great employers out here in Monterey County in California, and there are some employers that aren't doing the right thing. And we really want to be there for the workers to help them access any benefits that they need to. But even that wasn't enough, because we were seeing that in these crazy moments, workers weren't hearing about our helpline, and especially the workers that needed it most. And so I'm going to turn it over to Dr. Kennedy to talk about an intervention that we put together to make sure that the workers that really need those services get connected to it.
So I'm also in charge of our quality improvement department at the clinics, and we have something called Care Message, which is our texting capability. Ask people, do you want to come for your appointment? Are you going to come? Do you want to cancel? And it became apparent that we could text patients by downloading them from a program and text everyone in bulk. And so we created with Erin a text message for patients who had been, initially we started with patients who were tested positive for COVID so that we didn't overwhelm the 1-800 number. But eventually we moved to testing anyone who was getting tested. I'm texting them, because even if they turn out negative, maybe someone else in their family is positive and this information needs to get to them. And so it is nice because it is information with the phone number actually built into the text message, so people could touch on it and dial it. It is passive, so it is not in their face. It's not forcing them to do something. And it actually comes from a trusted source. You know, they know this phone number. They know that they just got tested by us. They trust us. And we're saying, this is an okay number to reach out to. This is not ICE. This is not someone else watching you. And I think that when providers are focused on all of these positive COVIDs, being able to have technology leveraged in order to send out this type of message is really ideal.
One of the key ways that we make that system work is because our medical legal partnership, we're actually already integrated into our electronic health record system, Epic. And so myself and our team of attorneys in our medical legal partnership are providers in Epic as well. And so we have that seamless integration and can make sure when care team messages go out that we can also be part of that care team and making sure that we're communicating with one another and that people don't fall through the cracks. And I think we see that when we look at that this 1-800 number is available to rural low-income Californians in 24 counties all across the state. And yet over half of our calls come from Monterey County, and that's in large part because having that number out there isn't enough. We really need to do those extra steps to get it to the people that need it most. And it's only by partnering with a clinic system that has access to those patients, it can help us make sure that people get that information in the moment that they need it, that we can have such a great response rate. And that's really one of the huge advantages that our medical legal partnership presents. And we see that in the different ways that it's being utilized in Monterey County versus other counties in California. I'm doing a quick time check, and I know that we might need to make some adjustments. So I'm on top of that, Alexis and Edis, just to let you know. I did want to get to another problem that we were seeing, and that's that we have the largest in the Monterey County and surrounding areas. We have nearly 5,000 H-2A workers, temporary agricultural workers, that come to our region every single year. And that's nearly double the amount of anywhere else in California. But we weren't seeing them come into our testing sites. And so we knew that there was a gap there in being able to access services. And that's because temporary agricultural workers are often or always in employer-provided housing that can be very isolated without connections to community services. And they often depend on transportation from their employer to leave to get anywhere, including the work site, but anywhere in the community as well. And so they can be really hard to reach population. And we knew that we needed to reach them in order to get services to some of our most vulnerable residents here in the county. Dr. Kennedy, do you want to talk a little bit about experiences that you've had reaching out to H-2A workers and some of the work we did?
Yes, I have had an opportunity actually to bring with me my 15-year-old daughter too. And I think it's in the top left-hand picture there is my daughter and I out at a hotel in King City. We went to the farthest reaches of our county. You can tell our county's pretty long. And it was an amazing response. This is a hotel that I think half of the rooms are occupied by H-2A workers. It became really clear to me that they're pretty isolated from the rest of the community. This is like, basically this hotel is next to a Burger King or maybe a McDonald's, and then the rest of the city is actually pretty distant from them. And they were very, we handed things out to them. We gave them information. Every door opened, everyone poured out to listen to us. I told them they were our heroes. They're away from their families and they're picking food for the Americans. They are doing work that is really important. I think they liked hearing those things. And I also was talking to them about the local clinic, which is an amazing Clínica de Salud de Valle de Salinas, has rapid testing, pre-testing, walk-in testing. It's doing it the right way. And I don't think most of them knew even where that was located. So empowering them, I work for the county, but I don't recommend you come to the county. I recommend you go to the one that's right here that's doing the right job. And I think that it was amazing to me that they are kind of cut off from all this other information. They don't have physicians. And I think that this type of outreach was really, some of our other providers came to some of these other locations, and I think it really oriented us more toward agricultural workers than we'd ever been before. So I think it impacted us dramatically, as well as them.
It was a great experience, and I was able to accompany that outreach as well. And really unique to have doctors and lawyers and our great colleagues that work at our organizations together jointly doing outreach. And We felt like it was a really successful model because as we had been doing outreach as a legal organization, we were getting a lot of questions that we weren't in the best position to answer about medical questions about COVID and about testing and about availability of services. And the workers themselves really wanted to see a doctor or medical professional and to know that there's somebody in the county that knows that they exist and that cares about them and is going to be there for them if something happens. And so it was really important to CRLA to do that outreach alongside medical providers. And I hope for the medical providers, it was a different experience getting out into the community and visiting these H2A housing sites, because you could live your whole life in Monterey County and not know that down the street there's an H2A hotel, and employers rented out the whole hotel. And one of the ways that CRLA was able to contribute is, I want to highlight the map that I've linked to in this slide, because it's a great map that shows all the different H2A contracts all across the country. It's an interactive map, so you can go to your region no matter where you are in the country. And that's the way that we were able to identify the specific housing locations, who we wanted to target, how many workers would be there, how much PPE we needed to bring to distribute. And so it was great that CRLA was able to bring some of our expertise in looking through H2A tools and contracts to really identify the most impactful areas, and then go out there with our healthcare partners to let them know where is the closest clinic that they can get tested, when is the appropriate moment to make sure they're wearing PPE, and to be particularly cautious, for example, in shared transportation or wherever it might be. And of course, to provide them our 1-800 number should anything happen. And that might be the only link that we can ever have with those workers. And it was a really meaningful moment. And we've seen some of those results in H2A workers, both coming into clinics more and also reaching out to CRLA more with COVID-related issues. I'm looking at the time, and unfortunately, I don't think we'll be able to get to our third topic, which is about how we realized we needed to transform some of our individual approaches to reach higher systemic levels of change. Like, what is the process for close contacts when it takes place in a field, and how is the county going to respond to that? Or what is the policy for returning COVID positive patients to work when they have a work clearance from the county, but their employer is requiring a negative test? Or how do we get more PPE to the Valley? So we put together a great coalition with all these diverse stakeholders, each that have made amazing contributions, and some partnerships that aren't as common, like California Rural Legal Assistance and being part of this group, and other worker advocacy organizations working side by side with our ag industry and growers. And that's something that hasn't taken place very much, but to all of the stakeholders' credit in this group, we've really focused on what our common interests are and what we can do together. And it's gotten us some good results in bringing in PPE and new testing sites, going out in the field to do education programs, thanks to our great county hospital Natividad and other folks like at Salinas Valley Memorial Hospital. And of course, more medical integration into the safety policies that are out in the fields with our ag industry. And the last thing I'll say about this is, one of the really key things that we wanted to get out of this was elevating the role of primary care providers in our COVID response strategies, because sometimes primary care providers were being left out of knowing that their patient was COVID positive and being able to respond to that and provide that individual care. And we felt like this coalition was a key way to get Dr. Kennedy's staff and others keyed in more to the core of what our COVID response is for farm workers. So I just want to end with what are some of the MLP lessons learned. And I know we're right at the end, so I want to just check in with you, Iris. Do we have time for that, or should I turn it back over to you?
Just in 1 minute, because we're almost at the end of the hour, and then we just have a couple of closing remarks.
Absolutely, I'll keep this quick. One of the lessons that we've learned is the value of having an MLP in place for these moments. And that's because, for example, when we needed to do outreach about replacement income, we already had those relationships with providers and knew how the clinic system worked to target our services and have a receptive audience to create that quick change that we need in this crisis moment. We also had privacy and confidentiality safeguards in place. We already are HIPAA compliant, CMIA compliant. We're integrated into the electronic health record in a way that provides all new tools for us and kind of takes care of some of those really thorny issues that we don't have to address in this crisis moment, and we can focus more on those substantive services. The clinic system has also taught us legal advocates about what are the legal issues that are harming their patients' health, like replacement income or others. And they help us access the most at-risk individuals. We wouldn't be able to reach COVID positive patients in that targeted way without working with the clinic system. And lastly, it's allowed us in working together to build partnerships with other stakeholders to address some of those higher level policy and systemic issues. And so we've seen a huge value to having a medical legal partnership, outside of this pandemic. But during this pandemic, that's only increased. And for, all the work that we've done and the amazing sacrifice that all of us on this webinar are making to be there for our communities right now, we have a lot more work to do. And so we're really determined to continue and to amplify some of the initiatives we've had. And of course, to learn from all of you and the great work that you're doing and thinking, what can we bring here to the Salinas Valley that will help our farm worker communities? Thank you all so much. It's truly an honor and a privilege. I'll turn it back over to you, Iris.
All right, thank you, Erin. So we are at the top of the hour, so I don't think we'll get the chance to go through questions right now. But we did put up our contact information on the slides and also in the chat, and we will have a recording available as well, so folks can email Alexis if you want to, or myself if you want to get a copy of that. I know there was a question of vaccines, for example, and Farmworker Justice and others are doing a lot of advocacy on that issue, so we can send some information on that. I also want to make sure people know that there's going to be an evaluation that's going to pop up at the end of the webinar. So if everybody could just take a few minutes or seconds maybe to just fill that out, that would be super helpful to have that feedback. This was put in the chat, but I just want to make sure everyone's aware that NCMLP and Farmworker Justice is going to be hosting a series of learning collaboratives on some of these issues. So if you're interested in those as well, or in other webinars on this issue, please do reach out to us. And thank you, everybody. We know everybody's very busy and doing very important work, so we really appreciate you taking the time to be with us for this hour today.